It's great meeting you all with the fifth academic cover lecture for this year. Now, let me begin with the good news for this year. We have created our very own learning module system. This would greatly improve our accessibility to the lectures and obtain CPT points with ease. Having LMS would greatly elevate our academic standards. So we will be sharing a video at the end of today's lecture with the instructions on how to get registered. Okay then, let's start. Today's topic is decoding back pain. And our resource person is Dr. Kusala 𝗙𝗦𝗕𝗦𝗪𝗓, consultant rheumatologist, District General Hospital, Matara. Dr. Kusala obtained his MBBS from the Faculty of Medicine, University of Colombo. Following his MD in medicine from the Postgraduate Institute of Medicine, Colombo, he went on to obtain his MRCP UK, FRCP London, FRCP Edinburgh, and FCCP Sri Lanka. Today, he is updating us on the management of back pain. So let me kindly invite you to commence the lecture, sir. Over to you, sir.
Good afternoon. Thank you very much for that kind introduction. Today, we are going to talk about the back pain. So during the first half of this presentation, I will talk about the back pain generally. During the second half, we will talk about the inflammatory type back pain specifically. So what is the most common problem with dealing with back pain? It is the prevalence. Back pain is the second most common symptom related to the related reason for clinician visiting in the United States. We don't have our own data here, but it is the second most common symptom related to clinical visits in USA. They say up to 85% of adults have low back pain at some time in their lives, but I think this is close to 100%. There is no adult who has not experienced back pain in their life. For many individuals, episodes of back pain are self-limited and resolved without specific therapy, fortunately. But some other back pain is recurrent or chronic. That recurrent or chronic type back pain can cause significant pain that interferes with our quality of life, also our employment. But rarely, back pain is a manifestation of serious medical illness, including infection, malignancy, or other systemic disease. So because this back pain is very, very prevalent, so dealing with back pain, so we have to identify who are the patients who require further assessment, investigation, and treatment. So this is the general, we are talking about the general back pain, not about the specific back pain. So what are common risk factors for chronic back pain? One thing is obesity, second is older age, female gender, physically strenuous work, especially jobs involving lifting, pulling or pushing objects, and jobs involving prolonged periods of standing or walking as a manual laborers were associated with a higher incidence of lower back pain. Also, unhealthy postures. This is very much common in young individuals who are studying in schools or classes. As well as physical strenuous work, also psychological strenuous work also can cause chronic back pain. Also, other psychological factors such as somatization disorders, anxiety, and depression can be risk factors for prolonged back pain. So these are the risk factors which are common in generally in people with chronic back pain. So still we are talking about the back pain generally, not about the one specific type of back pain. So what is the prognosis? The long-term outcome of low back pain is generally favorable. So in one prospective study has shown that 90% of patients seen for low back pain in the primary care, this is in case of primary care, did not seek care after 3 months. So they have become well with therapy or with the time spontaneously. Psychosocial factors are stronger predictor of long-term disability than the anatomical findings found on imaging studies. Other thing is patient presenting with acute low back pain there are various risk factors which predict that patient would go on to develop disabling low back pain at 1 year follow-up. So if the especially patient who have maladaptive pain coping behaviors, so they don't have healthy coping behaviors with regard to the pain, and also people who having functional impairment because of this back pain, or patient who have overall poor general health. So people who have back pain, or as well as other medical condition, and also various psychiatric comorbidities. So these are the risk factors which can predict that a patient with a acute low back pain can go on to develop a chronic back pain. So this is very important things, because when a patient or when an individual comes with a low back pain, we use various terminology, various words to label them or give a diagnosis. So we should know what these words specifically means. So one thing is that a common thing is spondylosis. What is spondylosis? It is a degenerative arthritis of the spine. See, it can be diagnosed in X-rays as a disc space narrowing and arthritic changes of the facet joint. It is the counterpart of the osteoarthritis of the knee joint. It is similar to that. So you can see this is a spondylosis, that you get the development of the bone spurs, and also there is a degeneration of the cartilage, and there is a narrowing of the disc space. Second thing is spondylitis. What is a spondylitis? Spondylitis is an inflammation of the spine. It is similar to rheumatoid arthritis or synovitis, affecting the peripheral joints. Third thing is the spondylolisthesis. This is also very common terminology we see in X-rays. So what is it? It is a spondylolisthesis is the anterior displacement of the vertebra on one beneath it. It is like this. So you can see that there is an anterior displacement of the C6 vertebra on the C7 vertebra. It is called the spondylolisthesis. Another fourth one is the spondylolysis. So that is there is a fracture of the pars interarticularis. That is where the vertebral body and the posterior elements, there is a fracture of the posterior elements of that protecting the nerves inside the spine. So you can see that this is caused, there is a fracture in the posterior elements of the vertebra. So it is called spondylolysis. Okay. So then we also see this word, it is spinal stenosis. What does it mean? It is a local, segmental or generalized narrowing of the central spinal canal by bone or soft tissue elements, usually due to the bony hypertrophic changes in facet joints and by thickening of the ligamentum flavum. So due to the various reasons, there is a hypertrophy of the bones, or hypertrophy of the or thickening of the various ligaments that can cause narrowing of the spinal canal. It is known as the spinal stenosis. So these are the common words we use mainly to give a diagnosis for a patient who are presenting with the back pain. Spondylolysis, spondylitis, spondylolisthesis, spondylolysis, and spinal stenosis. Also, we have there is a patients we have seen that they call the patient is having a radiculopathy. If a patient to have a radiculopathy, there should be an impingement of a nerve root, usually causing radiating pain, numbness, tingling, or muscle weakness that correspond to a specific nerve root. So there should be impingement or compression of the nerve root that which give rise to various neurological symptoms. Then there is a special type of radiculopathy which is known as the sciatica. So it is a pain, numbness, or tingling in the distribution of the sciatic nerve specifically. So it starts, it radiates down the posterior or lateral aspect of the leg, usually foot or towards the ankle. So radiculopathy, sciatica. Then there are some morphological changes of the spine. So it's called the kyphosis. It is an outward curve of the thoracic spine. Lordosis, inward curve of the lumbar spine. Scoliosis is the lateral or sideways curvature of the spine. Okay, so what is it? So normally when our normal spine, healthy spine has this shape. So cervical spine has a shape of lordosis. That means the curvature facing backwards. Our thoracic spine has a kyphosis. That means the curvature faces front. Then the lumbar spine again has a shape of a lordosis. Its shape is called the lordosis. So that means that curvature faces backwards, and also then the sacrum and the coccyx. So this is the normal spine. So when there is a lateral curvature of the if there is an abnormal lateral curvature of the spine, it called scoliosis. Scoliosis is always abnormal. In some individuals, there is a increase of the thoracic kyphosis. Kyphosis is the normal shape of the thoracic spine, but in some individual there is an increase of that shape. So it is called the kyphosis. And also in some individuals there is an increased lordosis of the lumbar spine. So these are called the lordosis, kyphosis, and the scoliosis. So these are the various words, various terminology we use to give a diagnosis or give a label to the patients who are presenting with the lower back pain. So differential diagnosis for lower back pain is vast. So we can divide this into main three groups. So first one is the mechanical lower back pain, then the non-mechanical spinal disease, and also various visceral diseases that which can give rise to lower back pain. So what are the mechanical causes which can give rise to lower back pain? It is a lumbar strain, degenerative disease, I mentioned it earlier, spondylosis, then the spondylolisthesis, then the herniated disc, spinal stenosis, osteoporosis, fractures, and various congenital diseases such as abnormalities of the shape of the spine, severe kyphosis or severe scoliosis, and also spondylolysis. So these are the various mechanical causes which can give rise to chronic back pain. Second group is the non-mechanical causes which can give rise to lower back pain. So we can divide them into various parts. First one is the various malignancies, especially the multiple myeloma, metastatic carcinoma, various blood hematological malignancies like lymphoma or leukemia, spinal cord tumors, and the retroperitoneal tumors. Especially this metastatic disease is very common in individuals who have the primary at another site. Various infections of the spine can give rise to lower back pain. So those are the osteomyelitis, septic discitis in our part of the world. TB can give rise to this discitis. Also paraspinous abscesses, epidural abscesses, bacterial endocarditis can give rise to lower back pain. Finally, other important group of non-mechanical spinal back pain is inflammatory type arthritis, which we are going to talk in detail later. So there are various diseases which can cause inflammatory type arthritis. I'm not going to talk about it here because we will talk about it in detail later. Also, various visceral diseases, that various diseases, abnormalities of pathologies of the internal organs can give rise to back pain, such as prostatitis, endometriosis, chronic pelvic inflammatory diseases, various renal diseases, especially renal calculi or pyelonephritis can give rise to lower back pain. Also, then aortic aneurysm, various gastrointestinal diseases, especially pancreatitis and cholecystitis can give rise to lower back pain. So these are the differential diagnosis we have to consider when someone presents with the lower back pain. Okay, so what we should do during the evaluation, because that as I mentioned earlier, this lower back pain is very much common in the community. Also, the differential diagnosis of lower back pain is broad. So what we should do, the vast majority of the patients seen in primary care have mechanical or non-specific lower back pain, meaning that there is no neoplastic, infectious or primarily inflammatory cause. So most important thing is, among all primary care patients with lower back pain, less than 5%, which we can call significant 5, will have serious systemic pathology. During the clinical evaluation, what we have to do is to pick up this significant 5%. Lower back pain is often attributed to disc degeneration. This is very much common thing which happens, which is the primary target for many diagnostic approaches. That means when someone presents with a lower back pain, one of the very common investigation we do is a X-ray. So, however, the importance of imaging finding associated with the disc degeneration, such as osteophytes, disc narrowing, and herniation, remains unclear. That means that if we do a spinal X-rays for 10 individuals above 60 years, most of them would have these changes, such as degenerative changes of the spine. But we should not label them having, we should not diagnose them having, we should not attribute their lower back pain to disc degeneration without doing further assessment or further investigation, because they may have, because this is very common. These changes are very common in the community, who they can have some other pathology. Muscular and also various ligament causes for lower back pain also very much important. So diagnostic uncertainty exists even those with back symptoms and well-described finding on the scan, as these findings are common even in the subjects without back pain and may be unrelated to the symptoms. That is one of very important take-home message. So these these various findings which we see on X-rays and also CT or MRI scans, they can be related, or they may not be related to their symptoms. So they should have further assessment depending on the other features. As an example, herniated disc can be identified in significant numbers of CT or MRI of patient with lower back studies in subjects with no back pain. So even we do a CT scan or MRI scan with the individuals without back pain, we may incidentally find that these herniated discs or some other degenerative changes. Okay, so how are we going to evaluate the patients with the lower back pain? So first one is what is very much important thing is the history. It is important to evaluate the 3 concerns in taking the history who is having back pain. So first thing is there evidence of systemic disease? Is there evidence of infection, neoplastic condition, inflammatory condition? Second thing is there evidence of neurological compromise? Is there neurological involvement? Third thing is there social or psychological distress that may contribute to chronic or disabling pain? Okay, so in the history, so we the patient presenting with the back pain, so we should take a pain history as we do it in the even in the case of abdominal. So site, onset, character, duration, radiation, relieving factors, associated features, and response to previous therapy. So these are the things we have to ask when we take the pain history. Okay, so other important thing is there evidence of systemic disease? So what are the things?
Sir, we can't hear. You are muted.
Some clue that patient is having some underlying significant systemic disease. It can be infection, it can be a malignancy, or it can be any other condition which involved in the abdominal or pelvic viscera. So these are the things you have to ask. So constitutional symptoms: fever, malaise, loss of appetite, or loss of weight. And second thing is a history of a cancer. So that means this is also very important. That's a 60-year-old female presenting with a 3-month chronic back pain versus history of 60-year-old female with a history of a breast cancer presenting with 3 months of low back pain is completely different clinical scenarios. That the second patient requires urgent assessment and further evaluations. Age over 50 years, duration of the pain greater than 1 month, especially the nighttime pain. Nighttime pain very common with nighttime pain which disturbs the patient's sleep. It is very much present in who are having any infective or malignant causes which can cause lower back pain. Also unresponsiveness to previous therapies, and also pain that is not relieved by lying down can be found in patient whose back pain is due to the malignancy or infection. So these are the important things we should ask during the history taking. If one of these or few of these are present, so that patient requires further evaluation. Okay, so how do we decide whether there is evidence of neurological compromise? Evidence of nerve root irritation typically manifests as sciatica. What is sciatica? Sciatica is a sharp or burning type pain radiating down the posterior or lateral aspect of the leg. So it ideally it should go below the knee level. So sometimes it is associated with the numbness and tingling. The unique condition is the 𝗦𝗨𝗕𝗦𝗕𝗦𝗓 compressive symptoms. There is a what is the difference? There is a saddle anesthesia. There is anesthesia in the gluteal region, and also there is a bilateral sciatica. Also there is a leg weakness, and also especially the bowel and bladder dysfunction with the urinary retention, with outflow incontinence. So these are the things you can ask from the patient during the history taking, whether there is a bowel or bladder, difficult to control the bowel or bladder, whether there is a urinary retention, whether there is a numbness in the buttocks, whether there is a leg weakness. If these signs are present, this is a medical emergency. Also neurogenic claudication, that means that especially the calf pain while walking to a certain distance. So these are the features we can ask from the history that which would indicate there is a evidence of neurological compromise. So during the physical examination, what we should do quickly? Basic physical examination should include the following components. First one is the inspection of the back and the posture. So back and the posture, if there is any abnormalities of the anatomy, so you can find out whether there is a scoliosis, whether there is an increased kyphosis or loss of lordosis, or whether the patient is having a bad posture. So range of motion of the spine. So you have to check the range of movement of the various segments of the spine, especially the cervical spine and the lumbosacral spine. You palpate the spine, find out whether there is any tender points. So it is very important to identify tender points which can indicate site of infection, site of fracture, or site of some kind of malignancy. Then various neurological examination. The very common thing we use is the straight leg raising test for patient with the leg symptoms. If the patient complain of lower limb symptoms, you should do a straight leg raising test, SLRT. And also at least you should assess the L5 at the S1 nerve root, because neurological testing should focus on L5 S1 nerve roots, since 90% of clinically important disc herniation occurs at L5, L4 and L5 and the S1 level. I will show you how to do them quickly, and also evaluate for any percent of malignancy. Breast examination, prostate examination, lymph node examination when persistent pain or history strongly suggestive of the systemic disease. These are very important. So how do you do the straight leg test? So patient in the supine position and hold the leg like this and raise it. So you should specifically ask for the symptom. That means that specifically ask there is a shock wave, current like sharp pain running down the leg, starting from the hip area along the posterior lateral side of the leg towards the ankle. So this that patient should tell that this symptom is present. So when you raise the leg, that when this happens, then you can take it as a SLRT positive. If the patient tell that patient is having that type of symptoms, it can be confirmed by dorsiflexing the foot. So that when you do this, if you dorsiflex the foot, that sign would exacerbate. So that is further confirm the presence of the positive straight leg raising test. So it indicates the sciatica. So L5 motor nerve root testing evaluate the strength of the ankle and the great toe dorsiflexion. So you can resist the ankle low great toe dorsiflexion to check the L5 motor nerve root weakness. If you want to check the S1 nerve root, the easiest thing is to evaluate the presence or absence of the ankle reflexes. These are the minimum neurological examination we can do if we suspect presence of any neurological compromise. Straight leg raising test to detect the sciatica, and also L5 motor nerve root and the S1 nerve root testing. Okay, so that is a history examination. So what are the investigation we can do? ESR, so basic investigation, ESR, CRP, and white blood cell count. These laboratory tests are most useful in detecting patients who may have an infection, malignancy, or infective cause, which can cause back pain. X-rays, radiological examination, X-rays, CT scan, MRI scans. So to which patients we should do these things? So again, back pain is very, very common symptoms. So almost all can present at some stage of their life with the back pain. So who are we going to subject for this radiological, various radiological investigation? So there are some guidelines. So the American College of Radiology has published a list of features based on patient's history, suggesting a need for radiological investigation to evaluate for potential complicated lower back pain. So these are known as the red flag signs. So any patient presenting patient who have a history of recent trauma, unexplained weight loss, any individual over 50 years, especially a women, and males with osteoporosis or history of compression fractures, patient with unexplained fever, history of urinary or other infection, individuals with immunosuppression or other chronic illnesses such as diabetes, history of cancer, history of intravenous drug abuse, individual with prolonged use of corticosteroids and or history of osteoporosis, individual over 70 years of age, individual patients with neurological deficits with progressive or disabling symptoms, duration, patient with a lower back pain, duration longer than 6 weeks, and also patient who has had prior surgeries. These are known as the red flag symptoms which may indicate that patient need urgent radiological investigation starting from X-rays, CT scan, or either MRI scan. Okay, so that is about the back pain generally. So again, that most common problem with patient evaluate a patient with back pain, that the PO prevalence, increased prevalence of the back pain. It is like investigating a patient with headache. So we have to identify individuals who need urgent further investigation and the assessment. So if we talk about the back pain, then I mentioned earlier, so back pain can be due to, most of the time, back pain is a, we call it as a mechanical back pain or non-specific back pain or musculoskeletal back pain. Then there is a back pain due to the infection, malignancy, or other systemic illnesses. Or third one is the inflammatory type back pain. So this is the group, that inflammatory type back pain as rheumatologists that mainly we deal with. Okay, so during this second half of this presentation, I'm going to talk a little bit about this inflammatory type back pain. So this is a uh, very important and so very unique type of unique group of individuals who presenting with the lower back pain. So to differentiate whether the back pain is inflammatory or non-inflammatory, the following 5 characteristics are used to identify the inflammatory type back pain. So first thing is, it is an onset of back discomfort or back pain before the age of 40 years. Insidious onset, pain improves with exercises or exertion, and also there is a no improvement with rest, and also pain at rest. So these are the 5 features that you should ask from the patient to identify the inflammatory type back pain. So the important thing is that the pain exacerbate with the rest. So most of the time patient complain the pain in the morning. Also, then the patient with inflammatory type back pain belong to a group, that is an umbrella term known as the spondyloarthritis. So spondyloarthritis is a group of disorders that there is a predilection to cause inflammation around the enthesis. I will talk about what is this enthesis later. So there is an enthesial inflammation which can lead to this spondyloarthritis type diseases. And also there is an increased prevalence of this antigen which we know, HLA B27. So as I mentioned earlier, so spondyloarthritis is an umbrella term. Under that, there are various specific diseases such as ankylosing spondylitis, undifferentiated spondyloarthritis, reactive arthritis, psoriatic arthritis, and also there's this spondyloarthritis in the younger people, in the pediatric age group, and also arthropathy associated with the inflammatory bowel disease, inflammatory Crohn's, and the ulcerative colitis. Okay, so if we talk about this spondyloarthritis, there are several common clinical manifestations. So what happens is that patient presenting with back pain. So the complaint of the patient is the back pain. So when we take the history, so I mentioned that 5 features. So we identify that patient is having a inflammatory type of axial joints pain common in the spine. So there is an inflammation of the axial joints. So then there are other 4 features which is unique to this individuals who are belong to this group, spondyloarthritic group. There is an inflammation of sacroiliac joint, sacroiliitis, and also there is a asymmetrical oligoarthritis, that's a peripheral joint involvement, especially of the lower extremities. Then there is a special thing known as the dactylitis or sausage digits. Then there is a enthesitis. Enthesitis is the inflammation at sites of ligamentous or tendon attachment to the bone. So these are the 5 main features of spondyloarthritis. So we'll talk about them a little bit in detail. So these are the clinical features. These clinical features, we can divide them into musculoskeletal features and also extra musculoskeletal features. So musculoskeletal manifestation of spondyloarthritis include inflammatory type back pain, peripheral arthritis, enthesitis, and the dactylitis. Inflammatory back pain is the most common symptoms at the disease onset. Usually 90% of the time patient present with the back pain. So you take the history, you identify the patient is having a sort of a inflammatory type pain from that 5 features I mentioned earlier. Then to evaluate further, you have to uncover from the patient whether the patient is having these other features. Peripheral arthritis. What is different between the peripheral arthritis of in this patient and the peripheral arthritis of the patient with a rheumatoid arthritis? As example, peripheral arthritis usually has an acute onset and predominantly involves the lower extremities, especially knees and ankles. However, any joint can be involved. Arthritis is typically asymmetrical. You know that in the rheumatoid arthritis, mainly patient is having symmetrical type arthritis, especially affecting the small joints of the hand, metacarpophalangeal joints and the wrist. In this case, this is a asymmetrical type pain mainly involved in the large joints in the low extremities, especially the knees and the ankles. The other unique thing is the presence of the enthesitis. What is the enthesitis? Enthesitis, this anatomical structure, enthesis. Enthesis is the site of insertion of ligament, tendon, joint capsule of fascia to the bone. That is the site of the attachment of a ligament, tendon, joint capsule of fascia to the bone. That site is known as the enthesis. The inflammation of that enthesis known as the enthesitis. So, enthesitis refers to the inflammation around the enthesis is relatively specific for spondyloarthritis. It is the specific and unique feature of the spondyloarthritis. The most commonly observable clinical manifestation of enthesis is swelling and the inflammation at the heels, which we know as the plantar fasciitis, and also at the insertion of the Achilles tendon, which is known as the Achilles tendinitis. Also, this second thing is the dactylitis. Dactylitis is a characteristic feature of the spondyloarthritis, including the psoriatic arthritis. It is that is a swelling of the whole finger or toe. Unlike synovitis, that is a inflammation of the joint, which in synovitis swelling is limited to the joint. But with dactylitis, entire digit is swollen. So this is the enthesitis, and the dactylitis are unique features of the spondyloarthritis. Okay, so this is very common thing. There's a Achilles tendinitis. We get the Achilles tendon in the back of the calf, and which goes and attached to the calcaneum of the ankle joint. So there at the insertion there is a inflammation. So it is known as the Achilles tendinitis. In the plantar fasciitis, also there is a plantar aponeurosis in the sole of our foot, which goes and attached to this calcaneum. When there is inflammation, we call it plantar fasciitis. So here in the Achilles tendinitis, patient present with pain in the back of the ankle. In the plantar fasciitis, patient present with the pain in the heels. Okay, so this is the dactylitis. You can appreciate that in here, so not only the joint, but whole toe is swollen. So there is inflammation of the joint as well as the soft tissues between these joints. So this is known as the dactylitis or the sausage fingers. So this enthesitis and the dactylitis are unique features of the spondyloarthritis. So those are the main musculoskeletal features of the spondyloarthritis. So what are the non-musculoskeletal features? So especially the inflammatory type eye disease, conjunctivitis, anterior uveitis are very much common in these patients. If a young individual presenting with history of the lower back pain and having 1 or 2 episodes of redness, pain, and the photophobia of eyes, which indicative of uveitis, so then you have to suspect whether the patient is having a spondyloarthritic condition. Also, there is an inflammation of bowel mucosa, inflammatory lesion of the bowel mucosa. So these are the non-musculoskeletal features which can occur in a patient with the spondyloarthritis. Okay, so in this group, I mentioned that there are 5 or 6 specific diseases: ankylosing spondylitis, psoriatic arthritis, arthropathy associated with inflammatory bowel disease, and also Rhesus or this reactive type arthritis can give rise to this type of inflammatory type lower back pain. In this group, common disease is so the ankylosing spondylitis. So what happens in ankylosing spondylitis? So the ankylosing spondylitis is a chronic inflammatory disease of axial skeletal manifested by back pain and progressive stiffness of the spine. So it mainly affects our axial skeleton. So it can affect the spine. It can affect the other joints in our axial skeleton, such as sternoclavicular joint and the costochondral joints, any joints in the, it has predilection to our joints in the axial skeleton. So other important thing is characteristically this affects young adults with the peak age of onset between age of 20 and 30 years. So young individual, especially a male, presenting with complaining of lower back pain for about 2 to 3 months or 1 year duration, and also some stiffness of the back pain. So we must consider them which individuals who needs further evaluation, especially if their pain is indicative of inflammatory type back pain. Other thing is other joints also can get involved, especially the large joints, hips, shoulders, peripheral joints, and even the temporomandibular joints can be involved. In addition, external organs such as eyes, lungs, heart can be also affected. So this ankylosing spondylitis is mainly an inflammatory type arthritis affecting the axial skeleton of a patient. So what are the clinical features? There is the clinical features of AS can be divided into those that arise from the spinal and sacroiliac involvement, hip and shoulder involvement, and other joints in the axial skeleton, such as the costovertebral, manubriosternal, sternoclavicular, and the costochondral joint inflammation. And also there is inflammation of the extraspinal entheses, such as the plantar fascia or the Achilles tendon. Then again, there can be peripheral arthritis, and also extra articular organ involvement also can be there. Okay, so lower back pain, the patient common complaint is the lower back pain. So it is a typically inflammatory type back pain. Then especially that we can inquire from the patient whether there is a gluteal or a buttock pain. This indicates sacroiliac joint involvement, which is, if it is present, it is very much indicative of presence of spondyloarthritis or ankylosing spondylitis. Although asymmetrical alternative buttock pain is common in the AS, it can progress to become the continuous or bilateral. Initially, the patient may complain of one side, but with the time they can have both side involvement with the pain and also tenderness over the sacroiliac joint. These are the most common two musculoskeletal features of ankylosing spondylitis: inflammatory type lower back pain and the buttock pain, which is indicative of sacroiliitis. So again, clinical features, then the patient when the time progresses, patient present with limited spinal mobility and the chest expansion. So there can be various postural abnormalities, which I show you some pictures later. Abnormalities may become apparent with years of the disease activity. So especially this is very slowly progressive disease that patient tend to disregard their symptoms, because at initial period they have a mild pain and the stiffness of the back of the spine. So especially these are young individuals. They easily attribute these symptoms due to their day-to-day activities, and they disregard these symptoms. They present for medical attention years after onset of these symptoms. So these in some individuals, when they present to the medical attention, these postural abnormalities already exist. What are these postural abnormalities? There is a typical appearance of these individuals. There is an increased flexion deformity of the neck, increased thoracic kyphosis and the loss of normal lumbar lordosis may lead to stoop posture. So this is what happened if we do not intervene. So this is the normal posture. So this is the advanced ankylosing spondylitis. You can see there is a anterior flexion of the cervical spine. There is a increased kyphosis of the thoracic spine, and there is a loss of lumbar lordosis. So this is how the patient progresses through the time. same individual. Okay, so this is the main clinical feature. So there is a limited spinal mobility and also the chest expansion. Also, there is a peripheral arthritis. I mentioned earlier, there is a oligoarthritis, pain, stiffness, and the swelling of peripheral joints may occur. Acute, non-erosive, and non-deforming involvement of single joint, monoarthritis or few joints. Oligoarthritis are more typical than chronic arthritis joint destruction. So more than the polyarthritis, most of the time these patients have a oligoarthritis. That's the involvement of less than 4 joints, especially in the lower limbs and the large joints. Then there can be a temporomandibular joint involvement. Patient complain jaw pain. Also, there is a enthesitis. Inflammation of the enthesis is a feature of the AS, ankylosing spondylitis, which I mentioned earlier, especially that plantar fasciitis and the Achilles tendinitis. So individual presenting with the back pain and also with the history of heel pain, then again they need further investigation. So because that is indicative of presence of a spondyloarthritis. Dactylitis, it is characterized by the diffuse swelling of the toes, and also constitutional features also common in this patient. They can complain of especially the malaise and the chronic fatigability. Okay, so those are the articular manifestation of the or musculoskeletal manifestation of the ankylosing spondylitis. So there are extra-articular manifestation as well. Most common extra-articular manifestation is the acute anterior uveitis. Unilateral uveitis is most common extra-articular complication. Cataract and glaucoma can also occur. As in any other inflammatory type arthritis, osteopenia and osteoarthritis also common in these individuals. Bone mineral density decreases in more than half of individuals with AS associated with long-standing and persistently active disease. Osteopenia or panc osteoporosis may predispose to vertebral fractures. And also there is a spinal involvement. So naturally there can be neurological symptoms as well. Neurological symptoms can occur by several mechanisms, including cord or spinal nerve compression, or due to the fracture of the ankylosing spine or the atlantoaxial subluxation. So there is an involvement of the cardiovascular disease. So it is a high risk of cardiovascular disease, especially the aortic regurgitation and various conduction disturbances. Then there can be pulmonary diseases. Many patients with AS, ankylosing spondylitis, have restriction in the chest expansion due to the involvement of the thoracic spine and also costovertebral joints. Also, apical pulmonary fibrosis can be developed. There is a renal involvement, especially the IgA nephropathy, secondary amyloidosis, and also there can be bowel mucosal involvement. So this is you may remember that in our medical faculty days we say there is a 4 A's, which can easy to remember with the extra-articular manifestation of the ankylosing spondylitis. There's a acute anterior uveitis. In the cardiovascular involvement, there is a aortic regurgitation. Pulmonary fibrosis, there is a apical fibrosis, which in this fibrosis mainly affect the apex of the lung. So there is apical fibrosis, aortic regurgitation, and uveitis, and the IgA nephropathy and the amyloidosis. So those are the 4 A's. Okay, so those are the things we can ask from the patient in the history. So how do you do a quick physical examination if you are suspecting a patient is having an ankylosing spondylitis? The most famous and the most commonly used test is this Schober's test. So it can indicate reduction of the range of motion of the lower back. Is the most common clinical of the AS, but this is not specific for the disease, but it is the most common clinical feature of the ankylosing spondylitis. How do you do it? You ask the patient to stand erect and you locate the 5th lumbar spinous process is marked by a pen. So additional marks are made in 10 centimeters above and 5 centimeters below the midline. Patient bends forward maximally and the distance between the upper and lower marks are measured. People with normal spinal mobility have an increase in measured distance of at least 5 centimeters. I will show you how to do it. So in the back there are 2 dimples. So they are indicative of the posterior superior iliac spine. So you mark this position and you keep the tape here. Even this is not essential that you keep this 0 this level and mark a position 10 centimeters in the patient in the erect position. Mark the patient, mark the point 10 centimeters above. Then ask the patient to maximally bend forward as much as possible. So then there should be increasing the distance of 5 centimeters or more. So if there is a less than 5 centimeters, it is abnormal. If it is less than 3 centimeters, it is very much indicative of reduced range of movement of the lumbar sacral spine. So this is the this is known as the Schober's test. So that what you have to do to detect the reduction of the range of movement of the lumbar sacral spine. Then I mentioned that this disease can involve the lumbar sacral spine as well as the thoracic spine as well as the cervical spine as well. So in the cervical spine, involvement can be detected by measurement of the occiput to the wall distance, provided another assessment of the spinal mobility. Increasing occiput to wall distance is associated with loss of lumbar and cervical lordosis with increasing thoracic spinal kyphosis. It is like that. So ask the patient to stand close to a wall. So the back of the chest and the back of the foot should be in touch with the wall. So ideally that the patient, that a normal individual should be able to touch the wall with the back of the with the occiput. In these individuals, because there is an increased anterior flexion of the cervical spine, so there is you can measure the distance between the occiput to wall. So if there is this indicate the involvement of the cervical spine. And also to detect the chest thoracic spine involvement, we can measure the chest expansion. So you mark the chest expansion is measured at the level of the 4th intercostal space. So what you do is you measure here for 4th intercostal space, ask the patient to take the full breath in and keep full breath in and measure the distance, and then take the full breath out and measure the distance. So normally there should be chest expansion of 5 centimeters or more. If it is less than 2.5 centimeters or 3 centimeters, it is clinically important. So these are the 3 tests we can use to detect, use to detect the involvement of the lumbar spine, lumbosacral spine, cervical spine, and also the thoracic spine. Okay, so those are the examination. So finally, what are the investigation? So there are not much investigation we can do to do for these individuals. So mainly laboratory tests, the assessment of the CRP and ESR and determination of presence or absence of the HLA-B27. These acute phase reactants, CRP or ESR level, should be measured in all patients suspected with ankylosing spondylitis. Theoretically, since this disease is an inflammatory condition, CRP and ESR should be high, but they do not rise as much as in other type of inflammatory type arthritis. As example, in rheumatoid arthritis, patient with rheumatoid arthritis, they can be very high level of CRP and ESR, but in these individuals, they do not rise as much as in those conditions. And also this HLA-B27 testing, also very much common test that we do in patients who are suspected to have ankylosing spondylitis or any type of spondyloarthritis. But what is the problem? Among Caucasians, HLA-B27 is present in 95% of those individuals with ankylosing spondylitis, but only in about 8% of the general population. And prevalence of ankylosing spondylitis in HLA-B27 positive population is only about 5%. So thus positive testing for 𝗙𝗢𝗕25 alone is not diagnostic. So that is the problem with this 𝗙𝗢𝗕27. What you have to remember is it is only a supportive test. It is not a diagnostic test. Presence of 𝗙𝗢𝗕27 in the presence of other clinical features can indicate presence of ankylosing spondylitis, but it is not a diagnostic test. You can exclusively exclude or diagnose the condition only with this 𝗙𝗢𝗕27 testing. It is only a supportive investigation. The main important investigation is the imaging. So all patients suspected with spondyloarthritis should have at least anterior posterior plain X-ray of pelvis to visualize especially the sacroiliac joints. If radiograph do not show any evidence of sacroiliitis, or if the diagnosis is uncertain, yet in those patients who are spondyloarthritis is strongly suspected, they should have a MRI imaging is the next step. Patients who have normal plain X-rays but inflammation by MRI are considered as having positive imaging findings of sacroiliitis. So if the patient who are suspected with this condition, you do a plain radiograph of the pelvis or the lumbar sacral spine, and also bilateral sacroiliac joints. An abnormal appearing sacroiliac joints on a plain X-ray is a hallmark of long-standing ankylosing spondylitis. Single anterior posterior view of the pelvis is generally adequate to document any diagnostically useful changes of SI joints and has the advantage of allowing assessment of the hips as well. So if you suspect a patient is having spondyloarthritis or ankylosing spondylitis, just take a X-rays of the pelvis or the lumbar sacral spine and also a bilateral sacroiliac joints. So if the clinical features are there, if there are radiological features, then you can diagnose the patient is having an ankylosing spondylitis. But the problem is to develop these X-ray features, it takes time. Initially, that patient may not have these features. So if you strongly suspect a patient is having this condition, but the X-rays are normal, then the next step is to do a MRI scan. If a plain film radiograph does not fulfill the above criteria for sacroiliitis, but the suspicious for AS remains high, next step imaging is MRI. With the MRI imaging, you can identify inflammation at an earlier stage. So this is the famous X-rays of the patient with ankylosing spondylitis known as the bamboo spine. You can see there's a calcification of the longitudinal ligaments, and there's a syndesmophyte formation. So this is the so if a patient presenting with this type of X-ray, that it is actually too late. So nowadays the goal of the diagnosing and the treatment is to prevent the patient to progress to this level. So that's why we have to suspect this condition by the clinical history and the examination at earlier stage and do the necessary intervention. So this is a normal sacroiliac joint. You can see there's in the patient with bilateral sacroiliitis, there are erosions, there are sclerosis, and also there are in some areas there's a widening and the narrowing of the sacroiliac joints bilaterally. So if this is present, it is the diagnostic of a patient is having the spondyloarthritis or the ankylosing spondylitis. So this is the which has been used for a long period, which is known as the modified New York classification criteria for AS, include requirement for both clinical and radiological findings. So this type of criteria mainly used for research purposes, but in the clinical scenarios, we mainly go by this clinical history and the other investigative findings. Okay, so a little bit about the management. As in management of any other type of arthritis, we can divide them into non-pharmacological treatment and the pharmacological treatment. Non-pharmacological treatment, patient education and exercise are important, especially the smoking cessation, which have shown to increase the progression of the disease. So smoking cessation is recommended for everyone who smokes. home exercises are effective, but supervised exercise programs, especially the physiotherapy, is very much important to maintain the mobility of the spine. In the pharmacological treatment, include one or more following things. Especially the non-steroidal anti-inflammatory drugs, NSAIDs, analgesics, sulfasalazine, and biological agents such as anti-TNF agents are important. Systemic glucocorticoids, prednisolone, have limited role, but intraarticular injection may be helpful in some patients. So, what is non-steroidal anti-inflammatory drugs? NSAID should be the first line of treatment for all symptomatic patients with ASA, unless it is contraindicated. So, in the other type of arthritis, if rheumatoid arthritis, we use NSAIDs mainly as an analgesics. But here, in the case of ankylosing spondylitis, so any spondyloarthritic condition, NSAID is the first line of treatment. So, other traditional DMARDs mean disease modifying anti-rheumatic drugs, including sulfasalazine, methotrexate, are not effective for ankylosing spondylitis patient with only axial skeletal involvement. That is very important thing. If a patient having diagnosed with ankylosing spondylitis, they only have the axial skeletal involvement, spine or the sacroiliac joint, there is no place to start these kind of traditional disease modifying anti-rheumatic drugs such as sulfasalazine or methotrexate. If in addition to the spinal involvement, if the patient is having peripheral joint involvement, then you can give these drugs. If the patient is not responding to these NSAIDs adequately, then next step of the management is the use of various biologics, which is available in Sri Lanka, such as infliximab, adalimumab, and the golimumab. This is a rough overview about the management of the ankylosing spondylitis. Okay, so finally, so any patient presenting with the back pain, acute or chronic, we have to think about these three main topics. So most of the time, patient is having a what we call a mechanical back pain or non-specific back pain or musculoskeletal back pain, but that should only be diagnosed or given the label after carefully excluding the possibility of presence of other two conditions. So you have to see whether the back pain is due to any infective malignancy or any other systemic illness or any patient with the inflammatory type back pain. So that's why you have to take a good history and do the relevant clinical examination. And if indicate enough, you have to do the required investigation, as I mentioned in the first part of this presentation. So what is the take-home message? Take-home message is simply if a patient presenting, patient with presenting with this lower back pain, do not miss the significant 5%. That means that rather than try to diagnose something, you should try not to miss anything. So that should be the take-home message. Because this is a very, very common complaint. This is a lower back pain. You should not miss this significant 5% patient who needs urgent further assessment and management. Thank you very much.
Thank you so much, sir, for that descriptive lecture, and hope to have you again with us in future academic programs as well. Let me thank our membership for taking part in today's lecture, and please make sure to sit through the video on how to register in our LMS if you haven't registered yourself as it. So thank you so much. Have a good day.